Imagine a child having their first seizure. They're then rushed into the emergency room, and doctors run tests. They treat the seizure and send the child home on anti-epileptic medication. But what if the real cause of that seizure was never identified? In many parts of the world, that hidden cause is a parasitic brain infection called neurocysticercosis. Neurocysticercosis, or NCC, is one of the leading causes of acquired epilepsy worldwide, but it still remains widely underrecognized in pediatric populations. Today, I'll be discussing how underrecognition of NCC contributes to the burden of pediatric seizures and how early detection can significantly improve outcomes. So, to start off with, neurocysticercosis is a parasitic infection caused by the pork tapeworm Taenia solium. When these larvae lodge into the brain, they form cysts that can trigger inflammation, seizures, hydrocephalus, and other long-term neurological damage. Globally, NCC is estimated to account for about 30% of epilepsy cases in endemic regions, so think Latin America, Africa, and Asia. Studies show that up to half of pediatric seizure cases may be linked to NCC. Despite all of this, it still remains significantly underdiagnosed, especially in low-resource settings where access to advanced neuroimaging is limited. Early diagnosis is critical. When NCC is identified promptly, antiparasitic treatment combined with anti-epileptic therapy can greatly reduce seizure frequency and prevent long-term complications. Because NCC-related seizures are largely preventable and treatable, this under-recognition, unfortunately, represents a major missed public health opportunity. So, to investigate this, I conducted a structured literature review using PubMed and Google Scholar. I searched key terms such as neurocysticercosis, seizures, pediatric, epilepsy, early detection, and treatment. Studies were ultimately included if they focused on children from birth to 18 years of age presenting with seizures and evaluated NCC diagnosis or treatment. Non-English studies and articles unrelated to seizure presentation were excluded. My screening process followed PRISMA guidelines, and after removing duplicates, I reviewed titles and abstracts for relevance, then performed full-text review. Data extracted included study location, sample size, diagnostic methods, NCC prevalence in pediatric seizure populations, and outcomes associated with early versus delayed diagnosis. The final findings were synthesized qualitatively to identify major trends, gaps, and its implications. Across studies, NCC accounts for a substantial proportion of pediatric seizures. Hospital-based studies in India, Mexico, and other endemic regions report that approximately 20 to 50% of pediatric seizure cases are attributable to NCC. Population-based studies show lower, but still significant numbers, generally around 10 to 30%. What's important is that countries that implemented important sanitation and public health measures showed declining NCC-related admissions over time. Seizures were the most dominant symptom in over 80% of pediatric cases. Most seizures were focal in onset, and they often progressed to generalized seizures. Single parenchymal brain lesions were especially common in children, but they were associated with better short-term outcomes. So in terms of diagnosis, MRI is the gold standard for diagnosis, particularly when the skull X is visualized. CT, although it's less sensitive, it's widely used in low-resource settings. Serologic testing can support diagnosis, but it does have its limitations because it can't really distinguish between past and active infection. Children with parenchymal disease treated with albendazole, corticosteroids, and anti-epileptic drugs generally showed lesion resolution and improved seizure control. However, extraparenchymal disease was associated with poorer outcomes and often required neurosurgical intervention. So, the main systemic barriers included limited MRI access, low provider awareness, inadequate serologic testing, and socioeconomic delays in seeking care. Overall, the literature shows that neurocysticercosis is both highly prevalent and highly treatable, yet it's frequently missed in pediatric seizure patients. Hospital-based studies often report higher prevalence due to referral bias, while community studies show lower rates. Diagnostic capacity is a strong influencer at detection. Countries with greater MRI access report higher prevalence, but it's important to note that this is not necessarily because disease is more common, but it's because it's better recognized thanks to the MRI. Regional variation in sanitation, pig husbandry, and healthcare infrastructure also play a significant role. In high transmission regions, underdiagnosis may exist alongside a heavy true disease burden. These findings ultimately highlight a clear clinical pathway. In endemic regions, children presenting with seizures should undergo early neuroimaging, with NCC kept high in the differential diagnosis list. So, the implications of these findings are significant. Early detection reduces seizure recurrence, limits long-term neurological disability, and decreases the need for invasive neurosurgical interventions. Based on the literature, some key actionable steps include implementing low-threshold imaging algorithms for children with new-onset seizures in endemic regions, expanding clinician education to raise suspicion of NCC, standardizing CT use when MRI isn't available, strengthening serologic testing as a supportive diagnostic tool, and continuing sanitation and prevention efforts at the community level. So, in conclusion, neurocysticercosis remains a major yet under-recognized cause of pediatric seizures, and improving early detection through better diagnostic access and clinical training does have the potential to dramatically reduce seizure burden and long-term neurological complications in children worldwide. This review is limited by the predominance of retrospective studies and variation in diagnostic criteria. Ultimately, pediatric neurocysticercosis is not just a medical condition. It's a preventable and treatable cause of lifelong neurological disability. By improving early recognition, diagnostic access, and provider awareness, we all have the opportunity to change the trajectory of thousands of children worldwide. Thank you so much for your time and attention. I'd be happy to answer any questions.